Hello, my name is Dante Bellai. This is my Amiqt presentation on Kennedy's disease. I encountered several patients that had who were suspected to have Kennedy's disease and that were still awaiting genetic testing. And this in part inspired me to put together a talk on Kennedy's disease today. So this is an overview. We'll move through definitions, signs and symptoms, pathophysiology of the illness, epidemiology, natural history, tests, treatment, case studies, research, and also a summary at the end. So what is Kennedy's disease? Kennedy's disease is known as essentially spinal and bulbar muscular atrophy, which is a rare progressive motor neuron disease with multi-system involvement manifesting as an androgen insensitivity, diabetes, sensory neuropathy, or also autonomic nervous system involvement. It's also known as X-linked bulbospinal neuropathy or X-linked bulbospinal neuronopathy. I also mentioned KD, Kennedy's disease. It's kind of the most commonly used term for it. It's a microsatellite and trinucleotide expansion disorder due to enlargement of the CAG receptor gene, the CAG repeat in the androgen receptor gene on the long arm of chromosome X. In terms of the symptoms and signs of Kennedy's disease, according to this comprehensive review of the condition, the predominant phenotypic characteristics of the disease include muscle weakness, wasting of the limb muscles and bulbar muscles, and respiratory muscles, muscle cramps, fasciculations, tremor, sensory neuropathy, breast enlargement, and erectile dysfunction. The autonomic nervous system can be subclinically involved, and we're going to talk about that a little bit later. Essentially, this is a lower motor neuron illness that is much slower in onset in comparison to perhaps ALS. So in terms of the pathophysiology of the illness, I talked about the androgen receptor gene essentially having far too many CAG repeats within it. So the AR is a nuclear receptor that is normally located in the cytoplasm and functions as a ligand-dependent transcription factor. This is bound to heat shock proteins when inactive, and normally it'll just bind to natural ligands, which are testosterone and dihydrotestosterone, undergo post-translational modification, nuclear translocation, DNA binding, and AR-mediated activation and repression of target genes. This can ultimately result in the exposure of co-regulatory surfaces AF1 and 2, so activation function 1 and 2, and a loss of androgen receptor function in people with Kennedy's disease due to mutations leads to this androgen insensitivity, which is thought to underlie some of the hormonal changes that we see in people with Kennedy's, like the gynecomastia or decreased fertility, for instance. In addition, when the CAG repeat is beyond 38, polyglutamine glutamine tract proteins affect different populations of neurons and cause neurons to degenerate within the body. For example, there's some evidence that anterior horn cells degenerate in the spinal cord in these patients. And this leads to those lower motor neuron signs that I talked about, like weakness, wasting, or fasciculations. The degeneration of the dorsal root ganglia can also occur, which will lead to sensory function interruption in distal extremities. And there's also a theory that mutant androgen receptors are toxic to muscle, leading to some of the myopathic features that you would see in these patients. So what's the epidemiology of the illness? So SBMA is essentially an X-linked recessive neurodegenerative adult onset disorder that is found in men. Women can be carriers, but they're usually not affected. SBMA is a pan-ethnic disease, and it has a prevalence of less than 1 in 40,000 men. Some geographical regions actually have a higher prevalence of Kennedy's, interestingly, and one of the most commonly cited examples in the literature is the Vasa region of Western Finland, where 13 per 85,000 male inhabitants are actually affected by this condition. These figures probably underestimate the true prevalence of the disease because of the large number of or misdiagnosed patients worldwide. It has been shown that up to 2% of patients diagnosed with ALS actually have KD. We're going to actually talk about that in a little more detail coming up. According to Atsudo et al., the length of the CAG repeat in the androgen receptor gene actually correlates inversely with the age of disease onset, with longer repeats being associated with earlier onset. So typically the onset would be from the age of 18 to 64 in the 4th to 5th decade of life. There's an excellent paper that's cited quite frequently in the literature that discusses essentially the natural history of the disease. So this is essentially a chart review combined with interviews of patients that were followed by neurologists for up to 20 years. These are all confirmed Kennedy's disease patients. And what they did is they essentially characterized different activities of daily living, and were able to correlate this with the age of onset of certain symptoms. So for instance, one would expect that on average in the cohort of patients by one's 30s, one would experience hand tremor. By one's 40s, muscular weakness and the use of a handrail when going upstairs. This progresses very slowly to dysarthria in the 50s, dysphagia, the use of a cane by the end of your 50s, wheelchair use being more commonly reported in one's 60s, and then of course aspirational pneumonia, which is one of the most common causes of death in addition to, well, respiratory failure is another one, but pneumonia is what they reported here, and then later death in one's mid-60s. So this differs wildly from motor neuron disease in the sense that it's a much slower onset. Someone with motor neuron disease, you would expect maybe a median survival of around 3 years with a very rapid, dramatic decline in motor function. Kennedy's is different in the sense that it's a very slowly progressive illness over time, and it is possible that a patient may live a normal lifespan. So in terms of testing, I'm found an excellent article, essentially. It's the French National Guidelines for the Management of Kennedy's Disease. This pooled together all sorts of literature and guidelines and professional opinion, and created essentially recommendations for how to test and treat Kennedy's. So one recommendation is electromyography in any patient that presents with signs of Kennedy's. So electrophysiological abnormalities typically extend well beyond the region affected clinically, unraveling extensive subclinical involvement. So the cue to look for is a decrease in sensory amplitudes or sensory neuronopathy in non-length dependent patterns, along with any kind of motor anomalies that you may encounter on examination. So for instance, this is one study that I countered a few years ago when I was preparing my systematic review on Kennedy's, that identified a difference between motor and sensory phenotypes in Kennedy's disease. So in this study, essentially, Kennedy's patients were examined. It was confirmed that they had Kennedy's, and then compound motor action potentials were measured and sensory nerve action potentials were measured in the median, ulnar, and tibial nerves respectively. And the group of patients was broken up into those with quite a long repeat, so over 47, and those with considered to be shorter repeats, so under 47 CAD repeats. It was found that those with a longer CAD repeat had more of a motor phenotype, whereas those with a shorter CAD repeat were associated with the sensory phenotype. So the compound motor action potentials were associated with, were decreased in a longer repeat, and the sensory nerve action potentials were decreased in a shorter CAD repeat. So not only can electromyography help diagnose the condition, there's actually this pronounced difference between motor and sensory phenotypes when examined. So patients can be classified into either group. And of course, the most important test of all would be genetic testing for Kennedy's. So we mentioned that it's a CAG triplet expansion in exon 1 of the AR gene on the X chromosome. If you're over 38 CAG repeats, that's diagnostic for Kennedy's. So PCR testing is what is recommended, in addition to, if possible, working on a family tree to try and establish if there's any carriers in the family or if any other members are affected. Testing of relatives that show signs and symptoms is also important as well. That's what's usually recommended. So in terms of what Pradra et al. Recommended, after essentially inviting the experts to comment on what is recommended as for treatment of Kennedy's, contacting organizations and reviewing relevant literature, and then going through an exhaustive process of multidisciplinary meetings, they came up with these broad guidelines for how Kennedy's should be managed. In general, for dysarthria, speech therapy is recommended. Occupational therapy is recommended to improve autonomy. Compensation strategies for swallowing are also recommended. Respiratory function has to be monitored because of the risk of aspirational pneumonia as one gets older. and monitoring for respiratory infection. Cough assist, breath stacking, and non-invasive ventilation may be used. Psychological support for the emotional aspect of the illness. It can be quite debilitating, and patients can really struggle with this sort of diagnosis and these sort of symptoms. And passive or active mobilization physiotherapy for those with poor mobility is also recommended. In terms of pharmacological management, there's little that really can be done, but in terms of pain from muscle cramping and aching, paracetamol, non-steroidal anti-inflammatory drugs, gabapentin, pregabalin, tramadol, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and tricyclic antidepressants are just some of the pain modulators used in KD. But the choice of specific drugs has to be guided by comorbidities. So one has to consider renal impairments, the risk of life dependency, and one's lifestyle factors as well. Fatigue may be managed by modafinil, levocarnil. Other means of managing dysphagia and maintaining adequate nutrition would be using consistency adjustments, texture changes with food, thickening powders, and gelled water, which may be recommended. And today we're actually going to explore an interesting research article that looked to try and improve dysphagia in Kennedy's patients. So that'll come near the end. But this is actually a point where there's quite a bit of research going into that right now. There's respiratory management of laryngospasms. So respiratory management includes physiotherapy, drainage and positioning interventions, insufflator, exsufflator devices, what we call cough assist, to clear the tracheal and bronchial secretions. Kennedy's patients are predisposed to developing Brugada syndrome. So to decrease the risk of VF and PVT, one must avoid strenuous exercise, excessive alcohol consumption, and certain medications in high doses like paracetamol, for instance. So this is a case study that I came across a couple of years ago when I was putting together my my systematic review, and I find it helps highlight a very important point regarding this illness. So this is a 29-year-old Afro-Caribbean male who had symptoms and signs including muscle weakness in his thighs, fatigue after exercise, fasciculations, cramping, and tremor since the age of 18. Over the past several months, he has also experienced similar symptoms in his fingertips. His feet usually feel cool, and he reported decreased sweating. Swallowing wasn't a difficulty, but he noticed some phlegm accumulating in his throat. No choking. Gynecomastia since age 16, testicular atrophy, issues with ejaculation, decreased hair growth overall. And there was perhaps a relevant family history as a 19-year-old first cousin with exercise intolerance and a maternal great-grandfather who had decreased mobility, but that wasn't confirmed by genetic testing. What they found was that ultimately, on examination, he had pronounced bilateral gynecomastia, fibrillations of his muscles, atrophy of his tongue, weakness of the orbicularis oculi and orbicularis oris, prominent perioral fasciculations, severe limb weakness in his shoulders, thighs, and toes bilaterally, and difficulty when standing. Sensory, so he had a loss of temperature and vibratory sensation in his fingers and toes. A tilt table test demonstrated orthostatic tachycardia, so autonomic dysfunction essentially, with heart rate increasing 35 to 40 beats per minute in the upright position in the absence of orthostatic blood pressure changes or symptoms. So essentially, he had a normal epidermal nerve fiber density compared to controls, and other lab evaluations and echocardiography were normal. What's interesting here is his CAD repeat, which I want to focus on. It's 68. So I mentioned that if you're over 38, you're considered to have Kennedy's disease. He has a repeat of 68, and he was presenting since age 18. So this really demonstrates that there really is an inverse correlation between the length of the CAD repeat and the age of onset of the illness. By age 29, he's already suffering terribly. And this is linked to a certain extent to the repeat and the mutation. So it really can have an impact on someone's outlook and the difficulties that they may face in life. So what's new in the world of Kennedy? So as I said, there is research going on, but it's more of a trickle. This is an orphan illness. It's very rare and it's not very well understood or very well characterized. But one type of study that's often going on, types of studies that have been trialed are androgen suppression studies. So it's thought that dysregulation of the androgen receptor can lead to testosterone toxicity, which may underlie some of the symptomatology that you see in Kennedy's, and that by suppressing androgens, one might be able to reduce essentially the severity of symptoms. And this study actually looked to improve dysphagia in SBMA patients. So 11.25 milligrams of leuprarelin, which is a luteinizing hormone releasing hormone agonist, essentially was injected subcutaneously every 12 weeks in 40 SBMA patients for the period of 1 year. Participants were assessed, their swallow was assessed by video fluoroscopic swallowing studies. So participants swallowed 3 milliliters and 9 milliliters of liquid barium, the same amount of curd type yogurt, semi-blended diet, boiled rice, 50 milliliters of liquid barium. And then they did a frame by frame video fluoroscopic study using a scale essentially. These were measured 1 month before the first injection and 1 month after the fourth injection. This is what they found. So what they were looking for overall was a outcome measure, which was pharyngeal residue. This was broken up into 4 categories: follicular residue after 3 milliliter liquid barium swallow, pyreniform sinus residue after 3 milliliter liquid barium, follicular tissue after consuming yogurt, and then piriform sinus residue after consuming yogurt. What was quite interesting about it was that in all, when you actually look at the follicular tissue and piriform sinus tissue, there's actually a reduction in the residue in both parts essentially. This is significantly reduced in both groups after the introduction of suppression therapy. In addition, what they also found, that when they were measuring the amyotrophic lateral sclerosis functional rating scale, which is essentially a scale that consists of 4 domains, including bulbar, fine motor, gross motor, and respiratory subscores, where each item is scored on a 4-point scale and a higher score indicating higher level of function. They found that after the use of AST, essentially, there was an improvement in the score overall, which was interesting. So the swallowing subscore was improved. Overall, they concluded that leuprarelin significantly reduced the pharyngeal residue in patients with SBMA after 1 year of treatment without any serious adverse effects. But they cautioned that longitudinal studies were needed to confirm the results. So, as I said, a current active area of research is looking at ways of using androgen suppression to potentially help Kennedy's patients. But unfortunately, more research is needed currently. There aren't very many studies in existence, given that it's an orphan illness. So in summary, KD is an X-linked recessive lower motor neuron disorder. CAG repeat of over 38 is pathognomonic for KD. It's a rare illness, therefore there's very little literature on it. There's very little that's known about KD. Current treatment involves managing symptoms, and currently there's no cure, unfortunately. Thank you very much for listening to my presentation. If anyone has any questions, please let me know. These are my references. Thank you kindly.